Hello everyone and welcome. I'm Manon Raap from the IAA and today I have the pleasure of speaking with Dr. Marco Valoroso, one of the leading specialists in knee surgery and in particular arthrofibrosis. Today's interview will focus on knee arthrofibrosis after total knee replacement, TKR for short. Since 2025, Dr. Valoroso has been the head of knee surgery at the EOC Hospitals in Lugano, Switzerland, where he is also part of the European Knee Arthrofibrosis Center, one of the very first dedicated centers for the treatment of knee arthrofibrosis. So today we're going to dive into his experience, his treatment philosophy, and what patients and surgeons alike should know about managing arthrofibrosis after a total knee replacement. Dr. Valoroso, thank you so much for being here with us. Could you briefly tell our audience a bit about yourself?
Thank you, Manon. It's a pleasure to be here. I'm Dr. Marco Valoroso. I'm the head of the knee surgery unit at EOC in Lugano, Switzerland. My clinical and research interests focus on advanced knee surgery with particular expertise in sport medicine, including ACL reconstruction, treatment of complex meniscal injuries, multiple ligament instability, and management of anterior knee pain. Now, my clinical focus is on complex knee pathologies, in particular arthrofibrosis, following total knee replacement. That is a condition that remains under-recognized and profoundly impacts the patient's outcome.
Okay, let's start at the beginning, diagnosing arthrofibrosis. Dr. Valoroso, when a patient comes in with a reduced range of motion after TKR, how do you go about identifying the problem?
So, thank you for the question. I'll begin with a true clinical assessment. Key indicators include persistent stiffness beyond 3 months, pain that is disproportionate to radiographic findings, and restricted range of motion, so typically less of 90 degrees of flexion or more than 10 degrees of extension leg. I also evaluate for mechanical block, infection, or implant misalignment.
And once you suspect arthrofibrosis, what imaging studies do you typically use?
So first of all, I use X-ray to assess the implant position and if there is some problem of the implant. But now there are other technologies that I can use like MRI.
Yeah. I know that metal implants can make imaging tricky. Are MRI centers with metal artifact suppression widely available?
Yeah, MRI with metal artifact suppression is increasingly available in a specialized center, through the access remain limited globally. At EOC, we are very lucky to have multiple 3 Tesla MRI systems that is equipped with advanced metal artifact suppression protocol, which significantly enhance soft tissue visualization around prosthetic components. This high-field MRI allows us to assess capsular fibrosis, synovial thickening, and periprosthetic inflammation with greater precision.
Okay, so we could say that you actually consider this type of MRI useful to diagnose arthrofibrosis in TKR knees.
Yeah, it's very useful, especially for visualizing soft tissue fibrosis, synovial thickening, and capsular contractures. However, I think that it's not essential for the diagnosis because the clinical evaluation remains the cornerstone of identifying arthrofibrosis.
Okay, excellent. Yeah, and let's say if an MRI is done, is there a magnetic field strength preferred for knees with a prosthesis, like 1.5 Tesla, for example?
1.5 Tesla MRI is preferred due to reduce susceptibility artifacts compared to 3 Tesla system. However, with the advent of advanced metal artifact suppression software, 3D MRI machines can now achieve excellent image quality even in the presence of prosthetic components.
Okay. And are there some types of prosthetics that can't go into an MRI scanner due to the type of metal?
So, most modern prostheses are MRI compatible, but cobalt chromium alloys may still pose challenges. So always verify implant specification before to do an MRI.
Okay. You already mentioned that the clinical assessment is the cornerstone of diagnosing arthrofibrosis. Is a biopsy necessary for its diagnosis?
Not routinely. Biopsy is reserved for a case with suspected infection or neoplastic prosthesis, but for sure, histopathology can confirm fibrotic tissue proliferation, but it is not essential for the diagnosis.
Excellent. Have you noticed differences in the presentation of knee arthrofibrosis in patients with or without TKR?
Yes, of course. In non-TKR knees, arthrofibrosis typically develops as a response to acute trauma or surgical intervention, such as anterior cruciate ligament reconstruction. In these cases, the fibrotic process is often triggered by direct injury to the joint capsules, hemarthrosis, or prolonged immobilization, leading to excessive scar tissue formation and capsular contracture. In contrast, arthrofibrosis in TKR patients tend to have a more insidious onset. It may not be immediately apparent postoperatively and often evolves gradually over weeks or months. The underlying mechanisms are multifactorial surgical trauma during joint replacement can initiate an inflammatory cascade. Or also implant malpositioning or oversizing can cause chronic mechanical irritation. Low-grade infection, often subclinical, can sustain a profibrotic environment within the joint. The factor contributes to a persistent inflammation, synovial thickening, and progressive loss of motion.
Let's talk about what might actually cause arthrofibrosis in a TKR. In your experience, is misplacement or improper sizing of the prosthesis a common factor?
Absolutely. Malrotation, overstuffed the joint, or improper soft tissue balancing are well documented mechanical contributors to arthrofibrosis following TKR. Malrotation, particularly of the femoral or tibial component, can lead to abnormal patellofemoral tracking, increasing the joint stress and persistent pain, all of which promote a pro-inflammatory intra-articular environment. Overstuffing the joint, often due to an oversized femoral component or an excessive polyethylene thickness, can increase tension in the surroundings of tissues, limiting motions and triggering a fibrotic response. Similarly, an inadequate balancing of the flexion and extension gaps may result in asymmetry loading and microinstability that can exacerbate the synovial irritation and a fibrotic response. So these biomechanical factors, if underestimated, can perpetuate a cycle of inflammation, pain, and progressive stiffness.
Okay. And low-grade infections, are these a frequent underlying cause as well?
These are very clearly recognized as drivers. Cutibacterial acnes and other bacteria like coagulase negative staphylococci may evade detection yet trigger persistent inflammation. And despite the absence of clinical signs of infection, such fever, elevated CRP, or purulence, this organism can sustain a chronic low-grade inflammatory response within the joint. This persistent inflammation promotes synovial hyperplasia, capsular thickening, and excessive extracellular matrix deposition, all of which contribute to the fibrotic cascade.
And TKR implant loosening can also lead to knee arthrofibrosis. Does this happen often in your experience?
Yeah, although less common than other causes, implant loosening remain a clinical significant contributor to arthrofibrosis following total knee replacement. Micromotion of the bone implant interface, often due to suboptimal fixation or progressive osteolysis, can lead to mechanical irritation of the surrounding synovial tissue, and this repetitive microtrauma stimulate a chronic inflammatory response, which in turn promotes synovial peplasia and capsular thickening. And additionally, where particles from polyethylene components or metal debris can activate macrophages and other immune cells, triggering the release of pro-inflammatory cytokines such as interleukin 1-6 or TNF-alpha. And these mediators drive fibroblast proliferation and excessive extracellular matrix deposition, leading to arthrofibrosis and joint stiffness. And clinically, these patients may present with pain, swelling, and progressive loss motion, often without sign of infection. So the diagnostic workup includes imaging to assess implant stability and laboratory tests to exclude infection. And for sure, management may involve revision surgery to address the mechanical instability and remove the inflammatory stimulus.
Okay, yeah, so I think that already largely answers my next question. So when you suspect a low-grade infection or an implant loosening being the underlying trigger, how do you go about ruling them out, and how do you treat them if confirmed?
When evaluating patients with suspected arthrofibrosis after TKR, it is essential to rule out underlying causes such as a low-grade infection or implant loosening, as these can significantly alter both prognosis and treatment strategy. What is my diagnostic workup? First of all, inflammatory markers. I begin with serum tests, including CRP, that is the C-reactive protein, and while not definitive, elevated levels may suggest an inflammatory or infectious process. I perform also joint aspiration. Synovial fluid analysis is critical. I perform aspiration under sterile condition and some samples for set count and differential, gram strain and culture. And it is important to have an extended incubation up to 14 days to detect low virulence organisms such as Cutibacterium acnes. And I also test alpha-defensin, which can improve diagnostic sensitivity. My radiographic evaluation starts from standard X-rays and CT scans to assess implant positioning and sign of loosening and periprosthetic osteolysis. And also nuclear imaging are very important. In fact, if a clinical suspicion remains high despite inconclusive lab results, I utilize nuclear medicine techniques such as SPECT-CT, which can localize infection around the prosthesis, or the PET-CT, which may help differentiate between infection and accepting loosening. What is the treatment approach if confirmed? For the infection, surgical options include irrigation and debridement, 1 or 2 stage revision arthroplasty, depend on chronicity and pathogen virulence, and for sure a targeted antibiotic therapy based on culture results. For implant loosening, revision surgery is typically required to restore mechanical stability. So important to remove the component and reimplantation with appropriate fixation. And the post-operative rehabilitation is always tailored to minimize the recurrence of the arthrofibrosis. I can say that early and accurate differentiation between infections and mechanical causes is vital, and misdiagnosis can lead to an effective treatment and worsening of symptoms.
Okay, let's move on to the next topic. It's a highly controversial topic, manipulation under anesthesia, or MUA for short. This involves forcing the knee to bend or straighten while the patient is under general anesthetic. and it's often performed without a surgical license of adhesions first. Some clinicians use it to try to improve the range of motion, but others have concerns that forcefully tearing tissues in the knee could actually worsen arthrofibrosis due to tissue damage, bleeding, or even bone fractures. In your practice, do you perform MUA at all? What are your thoughts on this topic?
In my clinical protocol, I never perform manual manipulation under anesthesia without first conducting a surgical lysis of adhesion. This ensures that any fibrotic bands or capsular contractures are released under direct visualization, minimizing the risk of uncontrolled tissue damage. Attempting to force motion through this dense fibrosis without pre-surgical release can lead to unpredictable tearing, bleeding, and further inflammatory response, which may worsen the arthrofibrotic process. So it's very dangerous.
Thank you so much. Specifically for patients with a TKR, are MUAs especially risky? Have you seen certain injuries from MUAs on TKR knees?
MUA performed without pre-surgical release of adhesion can lead to significant complication for sure, especially when dense fibrosis is present. In literature describe different significant complications, such as patellar tendon rupture. This is one of the most serious complications, often resulting from excessive traction during forced flexion, and it might require surgical reconstruction and significantly delayed rehabilitation. Periprosthetic fractures, particularly in osteoporotic patients, a force can cause these fractures around the femoral or tibial components, necessitating complex revision surgery. Component damage or loosening because excessive manipulation may compromise the fixation of the prosthesis, especially if micromotion is already present, and this can lead to early loosening or instability. And for sure, the arthrosis, so bleeding within the joint following this maneuver, can exacerbate inflammation and promote further fibrotic response, worsening the very condition the procedures aims to treat. And there are also described capsular tears and soft tissue injury. So forceful stretching of a fibrotic capsule can result in an uncontrolled tearing, leading to pain, swelling, and delayed recovery. For this reason, I do not perform MUA in TKR patients without first surgical releasing adhesion, either arthroscopically or via mini-open approach. This allows for controlled restoration of motion, minimize the trauma, and reduce the risk of iatrogenic injury. In my practice, precision and tissue respect are crucial, especially in the context of a prosthetic joint.
Okay, that totally makes sense. It's just way too risky. And moving on to surgery. When you operate on an arthrofibrotic knee, what techniques or approaches do you typically use?
In my clinical practice, I prioritize arthroscopic lysis of adhesion whenever feasible, as it allows for precise visualization and targeted release of fibrotic bands with minimal soft tissue trauma. This typically combined with capsular release to restore joint volume and flexibility. In more advanced cases, particularly when fibrosis is extensive or involves deep posterior compartments, after a posterior arthroscopic arthrolysis, a mini-open posterior surgery becomes necessary to achieve an adequate mechanical release and restore range of motion.
And what precautions do you take to reduce the risk of the arthrofibrosis returning?
Given the high risk of the refibrosis following surgical intervention, I implement a multimodal arthrofibrotic protocol postoperatively. This includes early mobilization, so initiating a passive range of motion exercises within hours of surgery is critical. I always use a continuous passive motion, CPM device, and closely monitor physiotherapy to prevent capsular retightening. I use also non-steroidal anti-inflammatory drugs such as Bruc and Celebrex, helping to reduce the post-operative inflammation and pain, indirectly limiting fibroblast activation and collagen deposition. And now I use also the pregabalin that it may help manage neuropathic pain in post-TKR patients. While it doesn't affect fibrosis itself, it can improve pain control, sleep quality, and tolerance to rehabilitation in selected cases.
Are there differences in your approach when performing a lysis of adhesions on a TKR knee compared to a non-TKR knee?
Yeah, absolutely. My approach differs significantly when performing a lysis of adhesion on a TKR versus non-TKR knee, due to the presence of prosthetic components that alter the joint anatomy. Infection control in TKR patients, the stakes are higher. Any suspicion of low-grade infection must be thoroughly ruled out before proceeding. There is also navigational complexity because the prosthetic components alter the joint's spatial relationship and limit the visibility. So in non-TKR knees, anatomical landmarks are intact and more predictable, while in TKR knees, for example, the intercondylar notch is occupied by the femoral component. The polyethylene insert can obscure access to posterior compartments, and scar tissue may be denser and more widespread due to the need for surgical trauma. So this makes arthroscopic navigation more challenging and increase the risk of incomplete release. And there are the risk to critical structures because in TKR knees there's a higher risk of damaging several structures such as patellar tendon, for example, especially if other surgeon do a prior MUA was attempted. The collateral ligaments, which may be tethered by fibrosis, and the prosthesis itself if instruments are misdirected or excessive force is applied.
And with arthrofibrosis and TKR, do you usually plan an open or an arthroscopic approach?
In my practice, I generally prefer an arthroscopic approach as the first-line surgical strategy for managing arthrofibrosis after total knee replacement. Arthroscopy offers several advantages. It's minimally invasive, allows for precise lysis of adhesion, and facilitates capsular release with reduced soft tissue trauma. It also enables faster recovery and lower the risk of wound complication. I opt for an open approach, or mini approach is better to say, in the following scenario. When there is an extensive posterior fibrosis, so when the fibrotic tissue is too dense or widespread, especially in the posterior compartments, arthroscopy becomes technically limited. So open surgery allows for complete visualization and true release. Additionally, I can choose an open approach when I suspect that the polyethylene overstuffing is contributing to the stiffness. So if the insert is excessively thick and limiting fractional extension, I may decide in selected case to replace it with a thinner polyethylene components to restore the joint balance and improve range of motion. But this decision is made intraoperatively based on the joint tension, gap assessment, and overall implant stability.
Okay, thank you. Yeah, very interesting. On to another controversial topic, TKR revision to treat arthrofibrosis. We hear that worldwide many patients are offered a TKR revision, even when their scans don't show any clear problem with the existing prosthesis. In your view, what's the rationale behind this?
In my opinion, revising a total knee arthroplasty without identifying a clear mechanism, a clear mechanical or infectious issues is not justified. Replacing a well-positioned and stable implant in the absence of objective findings introducing a significantly inflammatory insult to the joint, which may paradoxically exacerbate the arthrofibrotic process rather than resolve it.
So in those rare cases where a revision is necessary due to issues with the prosthesis, for example, mechanical issues, loosening or infection, is a hinged prosthesis then always required, or are there alternatives?
In the rare cases where revision is necessary due to mechanical failure, loosening, or infection, angioplasty is not always required. In fact, in clinical practice, I have never implanted a fully constrained angioplasty in patients with arthrofibrosis. Instead, I opt for highly stabilized implants such as posterior stabilized or semi-constrained design that offer enhanced stability without excessive constraints of a hinge. This approach allows for better soft tissue balance while minimizing the mechanical stress transfer to the bone implant interface. We must always remember that the more constrained prosthesis is, the higher the risk of accepting loosening and implant mobilization over time. Therefore, I reserve design only for cases with several ligamentous encephalopathies or major bone loss, but these are conditions that are rarely present in isolated arthrofibrosis.
Yeah, makes sense. Finally, are there situations where a tibial tuberosity transfer is indicated after TKR?
Tibial tuberosity transfer after TKR is rarely indicated, but in very select cases, it may be considered, typically when there is a significant dysfunction of extensor mechanism or persistent patellar instability that cannot be corrected through the soft tissue procedure alone. In my clinical practice, I do not routinely perform tibial tuberosity transfer in patients with arthrofibrosis because this procedure is not appropriate for stiffness alone, as it does not address the interarticular fibrosis or capsular contracture. Moreover, we must recognize that tibial tuberosity transfer can act as a significant inflammatory trigger, potentially reactivating the arthrofibrotic process. For this reason, I approach such procedure with extreme caution and reserve them only for cases where extensor mechanism alignment is absolutely necessary and cannot be achieved through less invasive means.
Excellent. Dr. Valoroso, thank you so much for sharing your insights on arthrofibrosis after TKR. Before we finish, is there one piece of advice you would like to give patients or clinicians dealing with this condition?
Thank you. It's been a pleasure to share my perspective. If I had to offer one key piece of advice, it would be this. Never underestimate the importance of early recognition and targeted intervention. Arthrofibrosis is a complex and multifactorial condition, but if addressed promptly, with accurate diagnostics, minimally invasive technique, and a structured rehabilitation plan, we can often prevent it from becoming chronic and debilitating. For clinicians, I can say resist to urge to rush into aggressive procedure like revision unless there's a clear mechanical or infection indication. Avoid manipulation under anesthesia. Precision matters more than force. And for patients, stay engaged in your recovery, communicate openly with your care team, and understand that stiffness doesn't always mean failure. It can often be resolved with the right strategy.
Excellent. Thank you so much. Thanks for joining us today. It's been a real pleasure.
It's been a pleasure also for me, and thank you for the invitation.
Thank you.